is better for people at younger age.
Yeah, at St Vincent's, our sort of upper limit as per our inclusion criteria is 60, but again, there's sort of biological age and chronological age, and so it's not a hard and fast rule. But I agree with Zoe, generally for individuals over 50, we haven't seen the same degree of stability in symptoms. Um, and 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 so one part is age, but also duration of MS. So ideally, in individuals who have had MS for less than 10 years.
Yeah. And so I guess following on in terms of symptoms and what people may experience post this treatment and what we've seen in clinical trials, um, two things I want to ask about. One is the long-term benefits, and certainly we've seen from clinical trials that people can experience quite long-term benefits from this. And one thing that people may have heard about if they've read about it is a thing called NEDA, no evidence of disease activity. So I want to talk a little bit about just explaining what that is. And how it relates to HSCT and what we've seen in that space, but also whether or not there's any potential for improvement rather than just stability. Because in some HSC trials, again, people may be aware of this with things like the EDSS, there are sometimes reported that, this can change and show some improvement. So I'd be interested in you both sharing some thoughts and insights on that.
Yeah, I'm happy to talk about NEDA. So as you said, Brett, no evidence of disease activities, no clinical relapses, no new MRI lesions or enlarging or enhancing MRI lesions, and then no disability worsening. So in most of the AHSCT studies, the follow-up has been sort of 2 to 3 years, and that's pretty standard for an MS clinical trial. So most of our phase 3 trials follow people for somewhere between 2 to 3 years. And we have seen across the different studies NEDA rates that sit at about sort of 70 to 90%. And so that's pretty impressive. It probably, we don't have great sort of head-to-head studies, but it probably sits a bit higher than what we would see in most of the disease-modifying therapy studies. Now, different studies have included different MS populations, and so the sort of better outcomes in regards to NEDA come in individuals or studies, sorry, where there has been predominantly relapsing remitting MS participants, and when we have studies that are a bit more heterogeneous, so more people with sort of progressive disease or some progression as well as disease activity, the rates are a little bit lower. In some single centre studies, we've had some longer term follow-up data. So we've looked at sort of our St Vincent's cohort out to kind of 5 years, and we're seeing NEDA in about 2/3 of individuals out to 5 years, and that's a probably 2/3 predominant relapsing remitting cohort. So certainly when sort of, used appropriately, we are seeing, long periods of kind of stability, both in terms of the EDSS score, but also, freedom from relapses and MRI activity. I have seen certain situations where we're more likely to see disability improvement. I'm very clear with individuals from the beginning that that is not the expectation. If that happens, that is a great result, but it's not the aim of the treatment. The times when I think that that is most likely and most reliable is when HSCT is performed very shortly after a recent severe relapse. So I can think of a few individuals that we've treated in the last few years who have had quite a severe sort of relapse with worsening of their disability scores to the, going from working through to being kind of wheelchair bound in a very short period of time, within 3 months. And in the few cases where we've managed to intervene with AHSCT in those settings, we've managed to get people back to their baseline before that big relapse. But that is really in that kind of hyperacute period, 3 months from when those symptoms, that relapse started to occur. And again, that is very rare. I definitely have people who have had improvement in certain sort of domains of their MS and certain symptoms. And the honest answer is I can't explain why that happens to some individuals and not everyone. So it's a win if it happens, but it's not the expected outcome.
And that's a perfect answer to all of that. It's a little bit of a leading question from me because I want to lead into a discussion that we also have with this, because when you have a treatment that then can lead to no evidence of disease activity and people see this over a period of time, we then hear the C word come out, and is HSCT a cure? And I think for me, when this question comes up in things that I do, this is where I pretty strongly lead into the A part of actually the full title, which is AHSCT, in terms of why I think that we can't ever think about this as a cure, because in the end, we're putting back in those same cells that at some point were triggered to start attacking. But I think it's a really important part of this discussion that we discuss that as something that people living with MS are obviously interested in, and your thoughts in terms of how you'd describe that.
No, I guess something I often say to people when they raise the cure word is that, there was a time where, for me, I thought that was the case. That part of the reason I wanted to go and do research in HSCT, and so, I did that as a fellowship, which is what you do at the end of your training to be a neurologist. And the reason that I pursued it is I really saw HSCT as a potential cure. And I suppose, unfortunately, as you say, Brett, it's not something that we can call a cure. And there's a few reasons for that. One is that there's a significant proportion of people do experience either relapses or disability progression post, and the disability progression in particular, really means that it doesn't cure MS for a lot of, it's not a cure, and isn't the answer for lots of people. But also, when you think about cure, you mean that you're not going to have any more MS or need any treatment for a very, very long period of time. And actually, that as Jen mentioned before, the longest follow-up data we've got is actually only 10 years in published studies. And so even for the people who had a transplant and hadn't had any new symptoms of MS at 10 years, we still don't really know yet what will happen in the decades following that. MS is as we know at the moment, is a lifelong condition. So we try and be very careful not to use the C word for people.
I think that, yeah, again, perfectly answers where we're at, and I think also comes back to that what we're learning more and more about the other processes that are happening beyond inflammation, and especially now the fact that we know they're happening from the earlier stages of disease, and that's not targeted. The other thing that I think we have to discuss when we talk about this for a treatment, and it's already been touched on a little bit, is obviously the safety side of it, and this is something that we've seen has changed significantly over the past decade, I would say. And Jen, I might start with you on this, because I know when we another time we had a chat about this on the ECTRIMS podcast, I think you really nicely explained this in terms of talking about front loading the risk. And I thought that was a really nice way of explaining this. So can we have a bit of a chat around the safety for
of course.
what the risks still are?
Yeah, so as I said, the treatment works not through the stem part of the stem cell transplantation, but really the chemotherapy that is used to ablate or to knock out the existing immune system. And so that's where the toxicity comes in, or the risks come in. So as Zoe said, we're using sort of fairly heavy doses of chemotherapy. Globally, there are sort of two common chemotherapy regimens used. They go by the names of BEAM and then cyclophosphamide. So one is a combination of 4 drugs and the other is just one drug combined. Both of them are actually combined with an immune immune sort of style therapy, which is called antithymocyte globulin. And so the role of the chemotherapy is obviously to try and eradicate all of the white blood cells that are causing MS attacks. But our chemotherapies are not very specific, and so in doing so, they tend to knock out not only all the white blood cells, but they can impact your red blood cell count and your platelet count, so the oxygen-carrying cells, but also your clotting cells. And so you can imagine that there are risks, certainly with knocking out your immune system down to zero, risks of infection, risks of bleeding, and risks of clotting. And then the chemotherapy itself can be toxic to your organs. So we're pretty vigilant at screening before we give chemotherapy, but classically the chemotherapies that we use can affect the heart, the lungs, and the liver and the kidneys. And most of those risks are seen in the first, what we call 100 days is the sort of highest risk period after the transplant or after the chemotherapy is given. But the risk of infection, the kind of immunological effects take really longer to fully recover from. So most people's kind of white blood cell counts don't get back to normal until kind of somewhere more like the 12-month mark. And so for the first really 18 to 24 months after stem cell transplantation, you do have an increased risk of infections. Early on, it's more bacterial and fungal infections, and later on, more viral infections. And interestingly enough, many people are worried about, family members or kids visiting and bringing bugs in, but it's actually the bugs that live in our mouth and in our gut and on our skin that are actually sort of more likely to cause those serious infections early on. So the list unfortunately continues, and I know this always sounds very, very grim. In the immediate sort of transplant period, people feel pretty rubbish. You get a lot of all of the usual chemotherapy related side effects: mouth ulcers, gut ulcers, pain, severe fatigue, diarrhea. Many people understandably want to know about hair loss, and guaranteed everyone loses their hair. And then in the longer term, there are effects on the immune system, which can actually cause sort of rarer autoimmune conditions. And Zoe and I have had many discussions, and she may want to talk about the effect on fertility, because that is significant, particularly when we think about where in the treatment paradigm this treatment is used. We've sort of paradoxically said it's better to use it earlier on, but that's also a time when people are often planning families, planning children. And longer term, again, a less significant risk, but anytime we give chemotherapy, it can damage all the cells in the body, and there is a slightly increased lifetime risk of things like squamous cell carcinomas and some other sort of cancers that occur with aging.
I'm happy to talk about the fertility just a little bit more too. So it's the strong chemotherapy that's used as part of transplant has an effect on sperm and eggs, and so actually infertility can occur for both men and women who have transplant. When I say can occur, I think probably happens in I think the data is in the majority, although people have gone on to have children without fertility assistance following transplant. For that reason, counselling about fertility and then banking of sperm and eggs is very important for people who may wish to go on and have families in the future. Although, of course, and it's fabulous that we have that technology now, but of course, it still makes having a family more difficult if you do require fertility assistance. So, it is a problem that fortunately we've got treatment to help us with, but it's a major issue for lots of people.
Mortality rate was obviously something we would often discuss with this as well, so risk of death. And that was a significant concern not too long ago, but where does that sit now? Obviously, with any treatment, any sort of medical procedure, there is always that risk. Where is that with HSCT and MS at the moment?
Yeah, so that's fallen kind of in every treatment epoch over the last 3 decades. So early on, we would quote a mortality rate of 5 to 10%. That was in the late 90s. That's very high. And then from sort of 2000 to 2010, that risk was quoted at more like 3 to 5%. And then from sort of 2010 2010 to 2017, we would say 0.5%, and now we quote a mortality rate of 0.1 to 0.3%. Very reassured and pleased to say that we haven't had any deaths at St Vincent's in individuals with MS. We have had some deaths in individuals who have had this treatment for systemic sclerosis or scleroderma, although that is a disease that has a far greater effect on the heart and lungs inherently. So those individuals generally have less heart and lung reserve. But I think this improvement that we've seen is really a reflection of probably two things. Predominantly having this treatment performed in centres where it's done frequently, and this is really to do with nursing experience. And we've got amazing nurses on our haematology ward who are so vigilant looking after our patients. And I think that is why we've been very lucky and not had any sort of catastrophic outcomes to date. And then the scientific part of it is probably the back seat there. We're probably a little bit better in how we dose these chemotherapies and how we monitor for chemotherapy-related toxicity, but I think it's really to do with nursing and a centre's expertise.
Excellent. So just as a reminder to people, we will be having a bit of a Q&A towards the end, so we're getting close to that time now, so do submit any questions that you may have, and we'll make sure that we answer them at the end. I think at this point, what's become quite clear is that this can be a really effective treatment for people living with MS, definitely for certain people living with MS, but now from the most recent discussion obviously comes with some risks, and it's not something to be taken lightly, which is probably now fitting into the where does this fit in the clinical paradigm. Obviously there were comments at the start around in some parts of the world this is used very early, and I don't know whether it will ever become a first line therapy, but interested in your thoughts on that. But before we get to that, more around, I guess, for our local audience in Australia and New Zealand, how is this being used, and is this available for anyone off clinical trial at the moment? Because predominantly and historically it had always just been available as a clinical trial. Is that still the case in this part of the world?
Quite well. Certainly different situation in Australia and New Zealand. With that, maybe we can talk about the New Zealand situation first. So we actually are not offering it as part of a clinical trial. We're offering it just as a treatment. And we are trying to collect information about people who do go on to have transplant in that way, but it's not part of a formal trial. The criteria, so one of them is age, so that it's about age between 18 and 55, and we also the criteria that the duration of MS is less than 15 years. Neither of those are completely hard and fast, but they're part of the criteria. The core part of the criteria for us is that we're looking for people who have experienced inflammatory disease despite treatment with a high efficacy therapy. So that means a clinical relapse and usually also evidence of inflammation on an MRI scan. Also, though, part of our criteria is people who have got inflammatory MS who are not able to have any of the high efficacy treatments. So, for example, people who we feel uncomfortable about treating with natalizumab because of JCV positivity, or perhaps people who can't have Ocrevus for another reason. And that area is a lot more tricky. And one of the reasons we have a group of neurologists around the country who sort of meet to talk about who we should recommend to have HSCT is that that questions about is HSCT the best treatment, or are there other options can be a little bit difficult. But so that's the core criteria. And I guess as you mentioned, Brett, the criteria we're using here are really about people who've tried other therapies first. We're not using it as a first line treatment.
Yeah, our criteria is very similar, and overall our model of care is very, very similar. So I joined St Vincent's in 2017, and we were performing AHSCT as part of a clinical trial at that stage. And through the collection of data that was generated through, individuals partaking in that trial, we then applied about 18 months ago to New South Wales Health to have this treatment registered as sort of a restricted access therapy. So for individuals who, essentially, as Zoe outlined, who have had inflammatory activity despite drugs like Tysabri or ocrelizumab, that they would be able to access it, with the support of New South Wales Health. We are still running a kind of parallel clinical trial. So if someone is eligible, it's not mandatory, but we would still ask them to partake in the trial, which basically allows us to capture all of those data points. Did they have a relapse? Did they have disability worsening? Did they just suffer complications? Because to be able to collect and store data in Australia, that has to be done with a degree of ethics and governance oversight. So so far, everyone has been very agreeable in partaking in the trial as part of having the treatment, but the treatment itself can be accessed purely with the sort of support of New South Wales Health. But we would like to continue the sort of governance structure that comes with having a clinical trial. In Victoria, there are 2 centres that are running AHSCT, again, as part of a clinical trial, and there's one and soon to be 2 centres set up in South Australia. And there are other centres that have performed AHSCT on a kind of I suppose, exceptional basis. So in Perth, in Queensland, in Tasmania, it has been performed as kind of a one-off, but without that kind of governance structure or state health service support. And as I said, our inclusion criteria is the same. And the other thing that we model as well is that multidisciplinary team approach, because it can be very, very difficult to to make some of these decisions. And so a panel approach is far more advantageous.
I should probably mention, so the New Zealand criteria are largely based on what symptoms it starts, which is why there's some similarity.
I mean, I think that's great, right? I think one thing that we would want is some consistency around guidelines for this. I think it makes it a lot easier for people, so it's good that's being done. One last question before we get to the submitted questions, and a number have come through, so thank you for that. We will be answering them. This is tough to answer in a couple of minutes, and I'm going to throw this one to you, Jennifer, just because I had the pleasure a couple of years ago of sitting in your presentation at ECTRIMS and listening to a very interesting talk that tied together our topic from tonight, HSCT, but also EBV, which is obviously a huge topic at the moment in MS research, and one that I know our audience is very interested in. So can you, in a couple of minutes, just sum up what you've seen in that space?
Yeah. So again, probably a lot of what I'll say to start is rehashing what the audience already knows. But Epstein-Barr virus is a very common virus. It's a virus that most people acquire either in childhood or in young adulthood, so sort of high school, university stage. So we know that probably somewhere between 95 to 98% of all Australians, and I assume the numbers are fairly similar in New Zealand, have been exposed to Epstein-Barr virus. What's interesting is it seems that probably 100% of people with MS have been exposed to Epstein-Barr virus. So clearly, Epstein-Barr virus in isolation doesn't cause MS, but it would appear from the kind of epidemiological data that you can't really develop MS unless you've also been exposed to Epstein-Barr virus. And so the question there is, does Epstein-Barr virus do something funny to the immune system that then triggers MS? Is Epstein-Barr virus the sole cause of MS? Does the virus go to the brain or go to the lymph nodes and directly cause the disease? Or is it a bystander of something else? Is there another phenomenon, another thing that is transmitted when Epstein-Barr virus is transmitted that may be relevant to MS? And the honest answer is, despite huge amounts of research, we don't have, clear-cut answers to those questions. But when we think about stem cell transplantation, it's really interesting because we know that Epstein-Barr virus lies dormant in our B cells, which is one of our immune cells that's highly relevant to MS relapses and MS attacks. And we know that the chemotherapy we use in stem cell transplantation kills off those cells. So in some ways, you can think of AHSCT as depleting Epstein-Barr virus's sort of reservoirs where it's hiding in the body. But at the same time, we know that once you lower the immune system, many viruses that lie dormant in our body can reactivate. And so we see this in people who have organ transplantations, kidney and heart and lung transplantations. Often, because their immune system is lowered, the Epstein-Barr virus starts to, replicate and can actually be very problematic. And so you would think that if that was sort of relevant in MS, that we would see huge flares of MS early after transplantation, and that's obviously not the case. And so the other question is whether it's this disorganized or dysregulated immune response to Epstein-Barr virus that may be relevant to MS. And so if you're pressing reset on the immune system, then maybe that is why it seems to be effective. And certainly our research, and this was sort of mirrored by some work coming out of a large group in Germany, was that the T cell response to Epstein-Barr virus is certainly very, very different after stem cell transplantation. Now, whether that's directly relevant to how stem cell transplantation works, I would certainly reserve comment, but it was interesting, and I think it certainly warrants further exploration.
Thank you. Excellent job of summarizing a huge area of work and a complicated area of work in a couple of minutes. I would not have been able to do that well. So on to our community questions. We've had a number submitted through Zoe, I think a couple very relevant to you to start with. So there's some questions around the cost of this treatment for people in New Zealand. So firstly, roughly how much it would cost and whether or not in New Zealand it's publicly funded if the person qualifies for the type of treatment.
So there's certainly no health care cost. It's done via the public system. I guess it's good to acknowledge, there are a lot of financial costs to people having to go transplant, even if you don't have to pay for the actual therapy and there's time off work and things. And there's no kind of public support for that. But the treatment itself, if it's done in the public system, is completely funded.
Okay. And another question around location. Is it only limited to Auckland?
No. So in fact, most of the transplants we've done recently have been done in Christchurch. So I guess as it's been mentioned earlier, this is a treatment that is done for hematopoietic conditions, like some blood and lymph cancers. And so it's the hematologists who actually manage the treatment, and they're very experienced in doing so. And actually for a hematologist, doing an autologous transplant is something they consider a fairly gentle treatment compared to some of the other treatments that they need to provide for people like allografting. So there are a few haematology centres in New Zealand that do autologous transplant. Auckland is definitely one, Wellington is definitely one, and so is Christchurch. And I apologise, I meant to look up the full list of them. There might be others such as Palmerston North. But it's a very long answer to say there's several centres in Auckland. It's still large-ish hospitals, but we're not just limited to one place.
Perfect. Thinking outside of New Zealand, we've also had some questions around more global centres, and this is obviously something that got a lot of media attention, especially from some high-profile people and other stories that appeared in mainstream media around people travelling quite long distances to get HSCT, people living with MS. So there's questions that have come through around Mexico and Russia in particular about these centres, and any thoughts around, is this a good place to get it done? Should people be travelling overseas to look at this for through private clinics as opposed to going through their local systems? I think quite a difficult question to answer, but see what we can say.
Is it difficult? I guess a few things to say on that. One thing I guess is always important to keep in mind about the overseas centres is that they are paid for service, and so they're places that are incentivised to encourage people to have HSCT because they charge for it. I probably wouldn't travel to Russia at the moment. That's the second thing to say. And if you're a person, I guess, who is in New Zealand and are thinking about having transplant, but you think that you won't meet the criteria, please just come and talk to us about it. I'm certainly happy to see people in the Auckland region who are, thinking about having transplant. We, as an MS team, we've been sort of, doing quite a lot of seeing people who have been seen by other neurologists in general, so like that's not really an issue. But please come and talk to us about it rather than kind of going off and doing it, and then we can talk through the pros and cons, and also make sure that you're not eligible in New Zealand too.
Jen, anything you want to add to that?
Yeah, no, I mean, I think we run a very similar system. So I would say for people who have had, inflammatory activity, relapses or new MRI lesions in New South Wales, despite being on therapy, they would be eligible to receive treatment here. And I would generally encourage that over traveling, to Russia or to Mexico, partly because there is no cost, but also, I think our safety outcomes are superior. I agree with what Zoe said. So there's always, whenever there's a fee-for-service model, there's an incentive to, encourage people to pursue the treatment. A lot of what they're doing in Mexico and in Russia is very similar to what we are doing. So certainly the Russian Centre has a fairly similar chemotherapy regimen to what we have had at St. Vincent's. In Mexico, they have far lower doses of cyclophosphamide than we routinely use, and they use another drug, rituximab, which is very, very similar to ocrelizumab, and it's run as an outpatient model, so the models of care are a little bit different, but the principle of what they're doing is the same. I think most people, in my experience, who have travelled overseas are sort of fall into one of three categories. So, as we said, at the moment, all of the evidence, and I think there's pretty much universal consensus that for individuals who have had new inflammatory activity despite a disease-modifying therapy, that HSCT is the most appropriate next step. But, for individuals who are interested in HSCT first up, as an alternative to currently available therapy, or for individuals who have got predominantly progressive disease but are still interested, that's typically the three sort of cohorts that I see traveling overseas. And certainly within, those populations, there will be people who benefit, absolutely. But I think it's very important that the risks of transplant, are adequately outlined, because they are also generally people who would get a similar benefit with therapies that are already available on the PBS in Australia. So it's it's really about trying to understand someone's rationale and being able to talk through, the likely outcomes with them on an individual level.
Yeah, and can I think just to add on to that and not to finish on it. We do have another question, so I won't be finishing on a negative note, but I think it's also worth noting that while there are obviously some excellent centres overseas that are doing this, we also know that there are centres overseas that probably are trying to take advantage of vulnerable people. And we've certainly seen instances of private clinics offering this sort of treatment that probably aren't offering any treatment whatsoever. Certainly, I had an experience where I contacted a clinic after was brought to my attention from a member of the MS Translate community who were interested in going there. I reached out to the clinic because their information that they were providing online was very minimal, explained who I was and what I wanted, and they wanted to charge me, I can't remember, this was a few years ago now, but they wanted to charge me $5,000 to get an idea of their protocol because someone would have to spend time to type it out. And I'm concerned if there was a clinic running that didn't have their protocol already documented. So I think, there's always just a notion in this that we be careful around these sorts of things, chase them up. But as Zoe and Jennifer both said, the starting point is to have a discussion with the people around who can guide you in the right space with this. So the last question that we have before I invite Nicola to come back in and close down the session, Peter's asked, will physio rehab help after HSCT? I guess the what happens post-transplant is an important question as well.
Yes, I guess that I would just comment from a New Zealand perspective, and yes, those things are absolutely important. I guess one of the challenges for us in New Zealand, because we've only done a very small number of transplants, is that there isn't there really isn't any well-established physiotherapy program specifically for people with MS who have had a transplant, and that is probably different from centres who have a higher volume. But yeah, it's definitely very important.
Yeah, unfortunately, I wish I could say that we have a streamlined approach, but we still have severe limitations on our kind of rehabilitation services. But absolutely, neuro rehab is vital, I think, to everyone with MS, but particularly after that sort of peri-transplant period where people do get very deconditioned, regardless of what puts you in bed for 3 weeks, be it a stem cell transplantation or influenza or, a leg fracture, anytime that you're immobilized or relatively immobilized for 3 weeks, most people find that their MS is a bit worse in the short term, and so engagement with physiotherapy early is really going to be a very important part of the rehabilitation.
Excellent. Well, look, let me take this opportunity as Nicola comes back in to thank you both, Jennifer and Zoe, for making my life very easy tonight and just such an interesting and insightful chat that I'm sure our audience will have loved. So thank you very much. Nicola, over to you.
Thank you. Just to reiterate that again, Brett, that it was just such a full coverage of the topic, and together with the what we know around the world, coupled with what applies to us here in New Zealand. So thank you both so very, very much, and to Brett as well for moderating the session, and to everybody who has joined us here tonight. Thank you so very much. Paul Marie, and see you again. Thank you.
Thank you.
Thank you very much, Nicola and Brett.
Yeah, thank you. And thanks for having me.
Yeah, good evening, everyone.
Thanks all. Bye.